Welcome to Chapter 12, the Primary Assessment, Emergency Care 14th Edition for the EMT. So we're going to talk about for the primary assessment. So the primary assessment, the basic approach to it is we're going to focus on life threats. We're going to check for airway, breathing, and circulation. And this primary assessment kind of depends on the patient's condition, how many EMTs we have on scene, and what other priorities we may have to assess as you assess the patient. So the order of ABC depends on the initial impression of that patient. So the sequence can vary. It could be ABC if the patient has signs of life, so airway, breathing, circulation. And if the patient doesn't have any kind of signs of life, then we're going to do CAB, which is that compressions, airway, and breathing. And then we're going to do any kind of immediate interventions that we may have to do. Decision making, so any vomit in the airway that enters the lungs is very serious and often fatal. Exsanguinating bleeding must be stopped immediately. And breathing and circulation are obviously vital for life, so you want to make sure that your patient is breathing and breathing adequately to support that life. If we need to make some immediate interventions such as bleeding control or CPR, and those aren't required, then we're going to shift to a less urgent mode and just kind of treat the patient based on what we see. Okay, so when we perform a primary assessment, there's some things that go into it. So we have a general impression, mental status, airway, breathing, circulation, and our patient priority. In the general impression, this is basically what you're going to do. Basically what you want to do is determine if your patient is sick or not sick. Sick patients, they need immediate care. They're going to use a lot of resources on your side. These patients do not look good. Okay. You're going to assess the environment, the patient's chief complaint, and appearance, and then you're going to help determine, and all of that helps determine the patient's severity. And it also helps set priorities for care and transport. A little bit later, I think we're going to talk about like your provider impression and your gut feeling, basically. That gut feeling plays a lot. Okay. I've been doing this for 16 years. My gut feeling, it's like a sixth sense, and it kind of kicks in when something just doesn't seem right. Spinal motion restriction. So we want to treat the patient's life-threatening conditions while not aggravating a potential spinal injury. So we're going to apply initial SMR to the head and neck on first contact with any patient that you may suspect have an injury to the spine. We're going to continue SMR throughout the call unless a physical exam determines it's not necessary. And we'll talk about those things a little bit later. Manual stabilization of the head and neck holds the patient's head still in a neutral inline position. There may be more than one way to restrict motion of the spine during the primary and secondary assessments. And EMS systems have specific guidelines for when to use and not use manual stabilization in SMR. Again, if you've been around EMS for any kind of length of time, you know that we used to backboard, strap down, C-collar, strap the head down all patients, no matter what kind of patient it was, if it was a fall. Now we no longer do that. And we don't transport on a backboard. We just put the patient in a C-collar if they have neck pain or any kind of pain when they move their head, and put them on a cot. So that's where we get all that from. So this triangle kind of helps you determine what the patient is, how the patient looks. Okay, so you want to look at their appearance, their work of breathing, and their circulation. You should be able to tell if your patient is sick or not sick within like 30 to 60 seconds of just looking at your patient. So appearance, you've got to look at their look, their gaze, their speech, and their tone, their muscle tone. Are they able to sit up on their own? Are they doing a tripoding position? Are they having difficulty speaking to somebody? All of those things. Breath sounds, grunting, flaring, gasping, that all goes into workup breathing. How well are they breathing? Okay, you and I sitting here, probably not having a whole lot of difficulty breathing. A patient who is in respiratory distress will have lots of work to try and breathe, because it is a lot of work. Okay, and then circulation. So we're going to look at their color. So color, their pallor, which is like a pale grayish tone. Mottling. Mottling is blotchy red spots that kind of indicate blood pooling. Are they diaphoretic? Are they sweating a lot? Do they have cyanosis? All of those things go into this triangle, and this triangle helps you determine whether or not your patient is sick or not sick. Again, 30 to 60 seconds, you should be able to tell where your patient's at. The look test. It's getting a feeling about the patient's condition from the environmental observations as well as the first look at the patient. Again, this is that sick or not sick. Can I determine that within that first 30 to 60 seconds? So it identifies patients who may be critical, patients who appear lifeless. We're going to resuscitate by beginning CPR, prepare an AED as soon as possible. Patients who have an obvious mental status, altered mental status, helps us to determine that. And patients who appear unusually anxious, and those who appear pale and sweaty can also be critical patients. Okay. Obvious trauma to the head, chest, abdomen, or pelvis. Specific positions that indicate distress include that tripod position for difficulty breathing, and a Levine sign for chest pain or discomfort. Levine sign is just, they've got a clenched fist up to their chest, and they're holding it there saying, oh my God, it hurts so bad. The chief complaint. So this is the description of why EMS was called in the first place. Okay, it can be specific. I have abdominal pain, or it could be vague. 9 times out of 10, it's more vague than specific. But it could be just not feeling good. So you've got to determine, what does that mean? Okay, what does not feeling good mean? And just ask the patient that if they tell you that. So forming that impression of the patient, we're going to look at the patient's age, sex, and position. We're going to listen for moaning, snoring, or gurgling respirations. We're going to smell any kind of hazardous fumes, urine, feces, vomitus, or decay. There are certain smells in EMS that if I walked in and smelled, I would be able to tell you what is wrong with that patient. UTIs have a specific smell. GI bleeds have a specific smell. There's not a lot of smells that I have yet to figure out or have smelled. There is one smell that I am not particularly fond of that I still haven't figured out what it was. It was a patient in a nursing home. They were in bed with like agonal gurgling respirations, and the patient had this just absolute horrid smell, and I didn't know what that smell was, and my partner, who had 10, 15 years in as well, didn't know what that smell was. Had never smelled a smell like that before from a patient. And so it was just, it was an odd smell, and I still haven't quite figured it out. Mental status. So we're going to use AVPU to determine mental status. So is the patient alert? What's their verbal response, or painful response, or unresponsive? Okay. So are they alert? Can they tell me who they are, where they're at, various things like that? And it's not necessarily just that, but it's also, do they look at me when I walk into the room? Okay, are they alert that way? All right, or do they only look at me when I talk to them, or do they only wake up or have some type of movement when some type of painful stimuli or noxious stimuli um, is produced? Or are they just completely unresponsive and not responsive to anything? So we're going to assess the ABCs. The order of the primary assessment will depend on the patient's condition, airway, breathing, circulation, identify and correct any kind of life threats, gather information that will help you later in your assessment. So again, EMS philosophy. Blood goes around and around, air goes in and out. If it doesn't, we've got to fix it. You have to fix those first three things in order to fix anything else wrong with that patient. Because if they don't have an airway, they're not breathing. Okay, if they're not breathing, they don't have blood going round and round. All right. So if the patient is alert and talking clearly or crying loudly, then the airway is typically open. Okay. They may not be breathing well, but their airway is open. If the airway is not endangered, is not open or endangered, we want to take measures to open it and clear any blockages. Okay, how do we open it? We open it with that jaw thrust maneuver, head tilt, chin lift. If we need to suction, we can suction. Put an oral airway in or nasal pharyngeal airway at this point. Okay, breathing. So situations calling for breathing assistance include if the patient is in respiratory arrest with a pulse, they may not be alert with inadequate breathing, has some level of alertness with inadequate breathing, and has adequate breathing but signs suggesting respiratory distress or hypoxia. Circulation. You want to assess skin. So good circulation is warm, pink, and dry, or warm, pink, warm, and dry. PWD, or shock. Okay, they may be in shock, which means that they are pale, cool, and clammy. And we're going to check for a pulse for no more than 10 seconds. Okay. 3 results of assessing a pulse. So it's either within normal limits, unusually slow, or unusually fast. I don't necessarily want to take a pulse right now. I can, but all I want to know is, does it seem to be within normal limits, or is it slower than normal, or is it faster than normal? Those are the 3 things that I want to know right now to determine if my patient is sick or not sick. Okay. Check for and control any kind of severe bleeding as well. And then we're going to determine the patient's priority. We're going to treat any kind of life-threatening ABC problem as soon as it's discovered. To be stable, a patient needs to have vital signs that are in normal range or just slightly abnormal. And then a threat to the airway, breathing, circulation, or any other either actual or imminent rules out stable. So that patient is now unstable. Okay. If there is no pulse, we're going to begin CPR compressions while the defibrillator is being readied. Again, you got to treat the ABCs as soon as they're discovered. And then stable, when I say stable, I mean that not sick patient. Okay. That not sick patient that says, hey, I'm okay. I'm just having some abdominal pain. Or the sick patient that may say, hey, what do we need to do? Okay. There are many times when it's not crystal clear on what a patient's problem is. So there may be many possible diagnoses, some more serious than others, and the patient's priority can change. Okay. Backing up, the many possible diagnoses. So when we diagnose a patient, we do a differential diagnosis, and we determine all the possible problems that could go wrong with that patient, and kind of figure out what's wrong with that patient. We're going to initiate priority transport if a life-threatening problem cannot be controlled, or threatens to reoccur. If the patient has a depressed level of responsiveness, we're just going to continue our assessment and care en route. Patient characteristics in primary assessment. So the patient assessment takes different forms depending on certain characteristics of the patient. They may have a medical problem or a trauma problem. They may have both. The patient may or may not have an altered mental status. The patient may be an adult, a child, or an infant. All of these things kind of go into what we'll talk about in later chapters when we get into like the secondary assessment, where we go based on these things. So if the patient is altered or unresponsive, are they an unresponsive medical patient or are they an unresponsive trauma patient? Are they a responsive medical patient or a responsive trauma patient? Child and infant assessments, we're going to do those a little bit differently because kids get scared at big burly guys coming at them. So we're going to do our assessments just slightly different for kids.